So good evening. My name is Hannah. I am a patient access coordinator with Northwest Medical Specialties, and I am also a member of the cancer support community. I wanted to introduce cancer support community and who we are. Cancer support community is the largest professionally led nonprofit network in the world, providing free cancer support to everyone in the community who has been touched by cancer. Through our partnership at Northwest Medical Specialties, we can bring free programming like these educational workshops, healthy lifestyle classes, social activities, support groups, and other resources and support. We do this so that no one has to face cancer alone. I'm just going to go over a few housekeeping rules. You have made notice upon entry that you are muted. We do ask that you remain muted for the entirety of the presentation. This way everyone can get the most out of tonight's presentation. And then we would also like to ensure that everybody's name is reflecting correctly on the Zoom. So if you just right click on your name, you can click rename and you can put your first name. If you have any guests with you, you can put their first names as well. And this will help ensure that we get everybody entered into the raffle drawing tonight after the presentation. So don't go anywhere after Dr. Veatch is finished, because you must be present to win. And then if you feel like you have any questions throughout the presentation, Dr. Veatch will stop at certain points and ask if anybody has questions. You can use the chat feature throughout the presentation. If you don't just want to like pipe in, you're welcome to use that feature. And then another handy tip, in the upper right-hand corner, there is a view button. If you click that and then select the speaker view, this will give you the best viewing option for tonight. So tonight's workshop is on lung cancer, and this is being presented by Dr. Veatch. Dr. Andrea Veatch is a board certified in medical oncology, hematology, and hospice and palliative care, with specialized interest in lung cancer, head and neck cancer, and other types of cancer. Dr. Veatch earned her medical degree from the University of Minnesota, Minneapolis in 1995, following residency in internal medicine at Mount Sinai Hospital in New York. Dr. Veatch went on to complete her fellowship in medical oncology and hematology at the Fred Hutchinson Cancer Research Center, University of Washington in 2001. Dr. Veatch worked with her independent grant support under Dr. David Maloney at the Fred Hutchinson Cancer Research Center until 2004, when she joined Northwest Medical Specialties. Dr. Veatch is involved in numerous clinical research protocols as principal or co-investigator in lung cancer and multiple other cancer types. Lung cancer is a multidisciplinary cancer requiring communication and coordination between no less than 3 doctor teams. At NWMS, Dr. Veatch and her surgical and radiation oncology colleagues in the community have held multidisciplinary thoracic oncology clinics since 2009. And with that being said, Dr. Veatch, I'll hand it over to you.
Thank you. That was really nice. So welcome everyone. I'm really honored that you would come and listen to some words about lung cancer. Hopefully you'll get something out of this and it'll be worth your time. And please don't hesitate to ask any questions about anything at any point if it triggers some thoughts that you have or want to share or anything like that. So, and then thanks also to this, to the cancer support community. They do amazing work. And as she said, it's a huge community and just angels as far as I'm concerned. So yeah, so we can just get started. The slides were prepared by the cancer support community. So just want to mention that. And here's some other information, some disclosures. And I don't have any financial relationships with any of the pharmaceutical companies. So we're going to talk about a few things, just basically, mostly just basic information. What is lung cancer, and kind of from a patient's perspective, how to optimize the experience with your healthcare team, some kind of basics about different types of lung cancer, different types of treatments, and some side effects and so on. So your loved one is diagnosed with cancer. It doesn't mean it defines you, and so that's the point. There's a lot of support and a lot of hope and a lot of education that can empower you to feel less vulnerable and scared, basically. So what is lung cancer? So it's the second most common cancer in both men and women, and it's the deadliest cancer in both men and women. The two main types of lung cancer are non-small cell lung cancer, which is all the cancers of the lung except for small cell. So small cell is a small population of lung cancer, and then non-small cell is most of the other types of lung cancer. So lung cancer screening is really important. It's probably the most important point of this whole presentation, which is that if lung cancer is caught early, the chance of survival and cure are much higher. And so a few years ago, Medicare has approved, and all of the lung cancer, like International Association and for the Study of Lung Cancer and ASCO and American Cancer Society all supported this. There was a clinical trial that with the United States Preventive Services, and it was really large trial. The numbers aren't here, but it was several tens of thousands of patients, and I think a lot of them were nurses. And so anyway, it basically took, the idea of it was to define the people who need to be screened for lung cancer, because previously when they tried to screen for lung cancer, it was a bomb and it didn't make sense financially. And so for all these years, I mean, mammograms have been used since the 60s, but lung cancer screening only just has come into, it's not even standardly done with a lot of primary care physicians, but it should be. And so the people that benefit from lung cancer screening is not the general population, but it's people who currently smoke or who have smoked previously and quit within the last 15 years, or people who have a history of more than 30 pack years of smoking. Just one second here. So, so they found that when people are screened with these criteria, that actually it saves a lot of lives, and so that's the whole intention. And it's once a year screening for 3 years, and in ongoing smokers, it continues once a year thereafter. And so when this was started, just to let you know, like there's been a huge stage migration of lung cancer. So a lot more early stage lung cancers have been diagnosed in the past few years, where previously it was mostly more advanced patients that came in for care. So non-small cell lung cancer makes up the majority of lung cancers, and the most common types of non-small cell lung cancer is adenocarcinoma, which is the most common, 60%, and then squamous cell, which is becoming less common. Adenocarcinoma is becoming more common, and squamous is becoming less common. And then large cell carcinoma is pretty uncommon. We see it, but it's not super common. And then small cell lung cancer makes up about 15% of lung cancers, and it behaves differently. It's more aggressive and it spreads through the bloodstream much faster. So it's even a very small tumor almost always has already spread into the bloodstream. And so it's much more aggressive and it spreads quicker and harder to treat. Most of the patients who have small cell have a history of smoking, but not all. And so it's a harder cancer to treat and to cure. So partnering with your healthcare team is really important. the healthcare team, generally when someone has earlier stage lung cancer, that they automatically get a team of doctors, and that includes a medical oncologist, which is what I do, and that's people who give chemotherapy and manage symptoms, mostly a surgeon, radiation oncologist, and then there behind the scenes, there's also all the pathologists, radiologists, and there's one more that I'm thinking. Anyway, another type of doctor. So you get a set of like 6 or 7 doctors working on you at one point, from the beginning of a diagnosis of lung cancer. And then in terms of the healthcare team, the social workers are extremely important. Just want to say that they're very, very important. And the nurses in particular, like the infusion nurses, there's a lot of people that go into helping people get through cancer care, physical therapists, speech pathology, nutrition is really, really helpful. And so the doctors are just one small component of the entire healthcare team. And communication is really helpful. It's so important to be able to elicit symptoms from someone. Some people are very stoic and it's very difficult to complain or to appear weak or to not want to ask for help, and it's makes it more challenging to take care of people who are more guarded. And so it's definitely helpful as a patient or as a caregiver to advocate for the person that you're giving care to complain and give as much information as you can. It's extremely helpful for all the people on the team taking care of a patient. This is just encouraging a second opinion, which is always a good idea, especially if it doesn't feel right, or even if it does feel right, but there's a little question or a little idea, it's just a really good idea to get a second opinion. Most doctors are not offended by this in modern times. And so I think it's always good you can just do it on your own. People don't need to ask the doctor, is it okay if I get a second opinion? A lot of times people come in having already had an opinion or a couple of opinions. And so you don't really need permission for this. This is a good thing to do, is to just hear it from somebody else. So that's one thing, is if communicating with your healthcare team is not effective, or for whatever reason, that's another reason to get a second opinion besides just the treatment decisions. So these are just kind of tips. Bring questions to appointments. There's some patients bring lists, or they have a book and they write down all the questions as they come up in between visits, and it's really helpful to have that as well as what happens, side effects and things like that. It's great. It's really, really helpful for people to write things down and help remember things. I love that picture. So the type of treatment for lung cancer really varies from the type of lung cancer, which is defined by the pathology, and the stage. And so sometimes people come in and we don't have like any information at all, and then it's really uncomfortable conversation. But you really need the type of cancer and the stage to be able to determine the treatment, and the treatment is often a multidisciplinary decision. And so it is helpful to have good communication in the team between across the disciplines of surgery, medical oncology, and radiation. A lot of times this communication is frequent, like all day we communicate to each other about patients. And so that's really helpful for also just for people to know that the communication is happening. They don't have to be the messenger in between the doctors, which is often like a phone game. So yeah, these are questions to ask your doctor. What treatments do you recommend? What are the side effects? How do you know if it's working? Clinical trials, and how to prepare for treatment. and then the support services and so on that are available. Financial cost is a huge burden and stress on cancer patients, and so that's definitely something to ask and get clear before starting treatment. I'm sure you guys know that the hospital systems have charity care for people that are not able to afford their treatment, and insurance is just like a crazy hornet's nest. And so we have, like at our in our company, we have financial counselors that spend all day long trying to help patients get their services covered and help get everything so that it's not a huge stress. So the treatment options for non-small cell lung cancer, again, depend on the stage. They also depend on the pathology. So inside of non-small cell lung cancer is adenocarcinoma or squamous, and those treatments differ a little bit. But these are the stages. So stage 0 means that it's like a precancer pathology. Stage 1 is early stage. So you can just think of like a tumor in the lung. Stage 2 is a big tumor in the lung with a lymph node in the same lung. And then stage 3 is a tumor in the lung plus lymph nodes in the middle of the chest, basically. And then stage 4 is when it's spread anywhere outside of the origin of the lung. So in the opposite side of the lung or anywhere else in the body, brain, bones, liver. And so usually surgery is offered for stage 1 and stage 2, not usually for stage 3B or higher, but sometimes for stage 3A, which is kind of a complicated stage. Radiation is, radiation has a role in stage 1 lung cancers for patients that are not able to tolerate surgery due to their lung function or just a personal preference to not have surgery. Sometimes radiation can be substituted for surgery in early stage lung cancers. And then radiation is the mainstay of therapy for stage 3. And then radiation is used for stage 4 in situations of pain or pending fractures, or sometimes like obstructive airways or physical symptoms that where we need a rapid reduction of the size of the tumor to help someone be able to be more comfortable. And then systemic therapy is what I do. So chemotherapy is basically drugs that are given to kill cancer cells in sort of a broad way. There's a lot of different mechanisms of how they work, but basically they make it hard for the cancer cells to divide and replicate. And that's kind of the standard, old-fashioned treatment, not old-fashioned, but very effective. But targeted therapy means treatment that's really targeting a mutation in the cancer that where the mutation is driving the cancer. And if that mutation can be blocked, then the cancer struggles with dividing or replicating. And so it's a real targeted therapy where it wouldn't affect cells in the body that don't have that mutation. And then immunotherapy is infusional therapy, IV therapy, that basically goes into the body, and the cancer cells kind of block or bind the T cells, and the T cells are part of the immune system. That's what happens naturally. The cancer cells physically connect to the T cells in the body and make the T cells inactive. And so the immune therapy basically is an antibody that binds a protein, and that goes in and cleaves that blockage. So then the T cells can wake up and see the cancer cell and say like, wow, you're foreign, I don't want you. And then you can start an immune response against the cancer cells, where before that, your body's really not able to mount an immune response against the cancer cells. So that's kind of like really basic, but that's what a person needs to know. So the surgeon is super important in lung cancer. these are the different types of surgery that are done for lung cancer, and it depends on the size of the tumor and where it is in the lung. So a wedge resection or a segmental resection means part of the lobe. Usually in lung cancer surgery usually involves removing the entire lobe that the cancer's in. So on the left side, there's 2 lobes, and on the right side, there's 3 lobes. And sometimes someone has lungs that would not tolerate the entire lobe removal, and or it isn't maybe completely clear that it's cancer, and it's basically like an excisional biopsy. There's some situations where a small section of the lung is removed, but that's generally not the standard cancer surgery, which would be a lobectomy usually. So lobectomy means taking out the lobe, but also it includes taking out the lymph nodes that are in that lobe. And so it's important. The reason it's important is because the cancer moves from the tumor to the lymph nodes that are inside that lobe. And if you just do a wedge or just a segment and you remove that, you still might have cancer in the lymph nodes. And so that you can't see maybe on a CAT scan or a PET scan. So that's the reason why a lobectomy is standard. And then pneumonectomy means taking out all the lung of one side. So both lobes on the left or 3 lobes on the right. And that's done in patients who have a tumor that's involving 2 lobes, or mesothelioma it's done. That's a tumor around the outside of the lung. But pneumonectomies are not super common. Kind of tough to survive after, not to survive, but to just challenging, I guess, with half the lung. So radiation is a lot of physics and stuff. It's pretty precise in terms of how they give the radiation. It's really come a long way just in the 20 years that I've been involved in cancer care. And so they do radiation that's a broad field. Like, for example, in lung cancer, say someone has stage 3, they'll treat the lung tumor and the lymph nodes in the middle of the chest. So it's kind of a broad area with a small dose every day for 6 or 7 weeks. Or they can do a small focused radiation, just the one spot, and only that spot. So it's like this really accurate 3-dimensional. In the lung, you're breathing, so it's a 3-dimensional tumor that's going up and down as you breathe, and they want to not get any normal lung, protect all the normal lung around it. So it's pretty precise, and that's why it takes so long to set up, in case anybody was wondering. From the time you see them until the time you start, it takes a couple weeks because of this modeling that they have to do. So yeah, radiation's used along with chemotherapy, sometimes before surgery, sometimes after. So there's always a different sequence depending on each patient's situation. Okay, so these are the chemotherapy drugs that are commonly used in lung cancer. Cisplatin is kind of like one of the first drugs that was used in the 60s, I think, actually, and it's used a lot for head and neck cancer, and it's actually, after all this time, still the primary drug that's used for head and neck cancer. And I think that might be the original one here, I'm not sure, but anyway, these are the workhorses of lung cancer chemotherapy. Does anybody have any questions? I can't see if you do. Hopefully Caitlin can.
Doesn't look like anyone has any questions right now.
Okay, sounds good. If you do, don't be shy. I was gonna stop before now and I didn't, so. Okay, so biomarker testing is kind of a little bit more modern type of evaluation for treatment that's really focused on more individualized as far as the cancer. So every cancer in all the different types of cancer has different kind of mutations that are relevant for treatment. And these are the ones for lung cancer. We have like guidelines, National Cancer, NCCN, I'm not sure what it stands for, NCCN guidelines, but there's a lot of guidelines, but the NCCN guidelines are really standard. And that always kind of points out which mutations should be tested in all the different types of cancer. And it's really rapidly evolving, and the recommendations are changing quickly. And so these are basically the most common. So the EGFR mutation, and ALK were the first two that were recommended, and now there's basically what's listed here, these 6 mutations, and then also PD-L1. These are usually they should be tested in all metastatic lung cancer, and some of them are tested in earlier stage lung cancer. And these are listed because each one has a specific targeted medication or chemotherapy drug that's demonstrated to be effective, more effective than standard chemotherapy. And when you look at how common these are and so forth, each one is not very common, but when you group them together, it's at least half of patients, I would say, or maybe, I mean, that's what, I'm not sure actually the percentage, but it's enough that it definitely makes sense to always check it in everyone, because if you get one of these mutations, it's really exciting because you can give some treatment that might be more effective and less toxic than standard chemotherapy. And generally, we try to test everyone with stage 4 lung cancer, but also, for example, in early stage lung cancer, like stage 2, EGFR mutation is commonly checked, and the PD-L1 is checked in earlier stages besides stage 4. So the biomarker testing, like what the heck is that? So that's basically when someone has a surgery or a biopsy, it's sent to pathology and they do testing on it. And then they say, you have lung cancer, it's adenocarcinoma. And then after they're done, then we send the tumor tissue to usually a second facility, but not always, that does a panel of testing for lung cancer. They test those 6 mutations. Or for kidney cancer, they'll check some other ones, but it has to be, it's not the standard. It has to always be requested, and it has to be sent out. And so there's some other steps to it. But the other thing that's kind of very exciting, and it is not completely as good, but sometimes it's very helpful, is to test the blood for biomarkers. And that's basically the idea is that the tumor cells are replicating and dying, and as they die, they break open and their DNA goes into the bloodstream. And then from there, when you check the blood, sometimes you can identify mutations from the DNA that's in the blood. So it's like circulating DNA testing, and they call it a liquid biopsy. Sometimes it's just a home run when you can diagnose on a liquid biopsy a mutation, and in like 2 or 3 days have the answer, and then have the person on medication quickly thereafter. It's not very common, but it's wonderful when it happens. And so the technology of blood testing has come a long way in the last 5 or 6 years, or maybe 10 years. So that's what this is all about. This is basically, I've already said this, but the problem is, just so that you guys know kind of the background on this, it is kind of tedious. So a person gets the biopsy, and then it takes 3 days or so to say it's lung cancer, and then you order the biomarker testing or next generation sequencing, and you have to send it to another facility. And so sometimes that takes a lot of coordination. And then when it's at that facility, from the time they get it going, it takes 2 more weeks to get the results. And so 2 to 3 weeks on the slide is kind of really optimistic compared to what it is in real life. But then you get a report that has all the mutations, like next generation sequencing lists all the mutations for the tumor, not just the 6 for lung cancer that are in the guidelines, but all the mutations. And then you can see those 6, and you can see a lot of other things that are not that helpful. And then you can also see genomic, meaning like hereditary mutations. So that's kind of the common way of testing for these mutations. Okay, so these are the mutations listed, and then this is like such an exciting, this is a great slide. In fact, I printed this slide when I saw it from this slideshow because I was just so happy to have it all on one page. These are all the mutations, and for each mutation, the different approved drugs that have been tested and are approved. So it's pretty exciting. This was not the case when I started. In fact, I don't know how long it is, but EGFR was probably the first one, and it's been maybe 10 years or so about that. So this is all really new, actually. Any questions on this? We'll move on to immunotherapy. So again, the immunotherapy is usually an IV treatment. It's an antibody made in a lab, and it targets a protein that connects the cancer cells to the immune system naturally. It blocks that so that the immune cells can become more active. And it's used in a lot of different cancers. It was started in kidney cancer and melanoma. Those 2 cancers are the most actively kind of monitored by the immune system, and the drugs worked the best and were initially tried in those. And lung cancer has had some really amazing success with immune therapy. It's really exciting, actually. The overall survival, or how long people live, I think the whole curves have changed because of immunotherapy.
I found this on the web.
So, but not everybody should be treated with it. It's not effective in everybody. Some people have a lot of toxicity from it. And the mutations that were on the prior slide, EGFR, ALK, a lot of those mutations are kind of mutually exclusive, meaning most people don't have more than one mutation, and people, and those are driver mutations, so they don't usually have a whole lot of other mutations. And so immunotherapy is more effective in people who have a lot of mutations. And so, for example, if someone has difficulty repairing their DNA, a hereditary condition where their DNA is not corrected, when it makes a mistake, they'll have a lot of mutations. And then there's a lot of targets for the immune therapy, and then it's more effective. And same with people who have been like smoking for ever and still smoking. There's just so much toxins and so much damage to their DNA that the immunotherapy just has more options and more more targets. And so it tends to be more effective in people who have more mutations. There's a test on the reports called tumor mutation burden. And that means like basically how many mutations a person has. Some people have very few mutations, but they're very effective to make the cancer. And some people have just a ton of mutations. And those are the ones that respond better to immunotherapy. This is kind of like super broad terms, but just to get the idea. So not everybody's a candidate for immunotherapy, but it's definitely a wonderful advance that's worth discussing and exploring. And so these are, there's 2 slides here of the drugs that are currently approved, immunotherapy drugs. And so Tecentriq, Imfinzi, Opdivo, and then Keytruda and Libtayo. So these are all basically drugs that are what I was talking about, immunotherapy, and given in different circumstances. Most of them require that people do not have like EGFR ALK mutations, because again, they are thought to be less effective, but also sometimes harmful to mix with the medications, the targeted mutation, oral mutations for those, medications for those mutations. Sorry. So anyway, these 5 drugs are all, every time you turn around, there's a new indication or there's a new, some new way to give it. And so there's a lot to keep track of, but really, really exciting. I have several patients actually that have had stage 4 lung cancer. The survival is not very, very good in stage 4 lung cancer without treatment. The survival is not very good, but I have several patients who have been on immunotherapy who have no evidence of disease at all. And it's just great. And some of them not even on treatment and they still have no disease. I mean, almost like we don't really use the word cure, but it's pretty exciting. Not a lot of patients, but it happens and it's just wonderful. Okay, any questions? Anybody have any thoughts or questions?
We haven't had anything come through the chat, but please feel free to unmute yourself if you have something.
Okay, so we're going to talk about small cell lung cancer now. There's basically 2 stages. Small cell is really easy in terms of the staging. It's defined as an area that can be treated with radiation or everything else. And so, so sometimes the radiation field will be kind of small, sometimes it's a little bit broader, but basically if all of the cancer is defined in a small area in the lung, then that's limited stage. If it's anywhere else, it's extensive stage. And again, this type of lung cancer is like a blood-borne cancer. It's quickly spreads to the blood and to other areas of the body. So it's not very common to have an isolated tumor that hasn't spread, but it does happen on occasion. So limited stage is treated with radiation and chemotherapy, and extensive stage is usually treated more with just systemic treatment and not with radiation. Surgery is used for small cell lung cancer in very rare circumstances, but if someone has a small tumor, then surgery can be used. And there is data to support the use of surgery in small cell, but it has to be a very small tumor, basically, and no evidence of disease outside of that tumor. Chemotherapy that's commonly used initially is the cisplatin or carboplatin and etoposide, and then with radiation for limited stage, and then extensive stage is usually given these drugs. They're kind of written in order here of what you would use, but basically the platinums and etoposide are commonly given first, and then lobectomy is given next, and then it's kind of any of the others can be given after that. And again, radiation therapy is used for limited stage. It's also used for, let's say someone has limited stage and they've received chemotherapy and radiation to their tumor. Radiation actually is given, whole brain prophylactic radiation is given because it has people who have received that have a longer survival than people who don't receive it, because the risk of small cell cancer going to the to the brain is so high that they actually do radiation even before seeing it in the brain. So it's called prophylactic cranial irradiation, and that's standard recommendation after chemotherapy and radiation for limited stage small cell. And then laser therapy is for on bronchoscopy. They can use a laser to open an airway, basically when the cancer is blocking the airway. So immunotherapy is also used in small cell, and actually has really pushed the bar forward for, I think it's like the first advance in small cells since the 70s or something, is adding immunotherapy to the standard chemotherapy for extensive stage small cell lung cancer, and significantly increasing how long people can live. And that was maybe, I'm not sure the year, maybe 5 years ago or something like that is when this advance was made. So clinical trials are a good ideas if it's appropriate for a person, if it, in a general sense, clinical trials are really the only way to advance the care of patients. Everybody who's getting treated for cancer is being treated with that regimen because it was checked in and studied in a clinical trial. There's almost no treatments that are given that were not studied in a clinical trial. So it's always something to consider for yourself, because you may not be able to get a drug otherwise, and also to help the people of the future behind you that would benefit from the results of a clinical trial. It's always a good thing to consider and to talk about, and to look into, and to check other sites, other areas where they're doing clinical trials, because it's not the same everywhere. So the Seattle Cancer Care Alliance may have trials that we don't have, and sometimes we have trials that they don't have, and things like that. So it's something that you can go on a website called clinicaltrials.gov, and it actually lists all the clinical trials approved that are ongoing in the country. And you can search under disease, keywords. It's like Facebook, though, you'll get lost. So yeah, so a lot of people don't trust clinical trials. They feel kind of like they're being tested on, and there is let me just back up. So there's 3 levels of clinical trials. There's phase 1, which is when the drug is new and it's in humans, hasn't been tested in humans, and it's like finding the dose. So there'll be 1 dose given, and then they kind of check like side effects, and then increase the dose, and then increase the dose, and then find the dose that too many side effects, we got to go back down and get the right dose. So that's phase 1. It's everybody gets the drug. It's just that they're getting different doses and checking for toxicity, and they're not really focused on whether or not the drug works. And then if it looks like tolerable and they get the right dose, then the next stage is phase 2 trials, and those are basically the dose is set, but we want to have a look to see if it's actually effective in a specific type of cancer. And so it'll be a small number of patients usually, and the comparison is historical controls. So people who have been treated with XYZ, and then they compare the outcomes of those people to the clinical trial. And so there's some difficulties with that comparison, and it's not good to jump the gun on those type of comparisons, because they can be heavily biased. And so that's the reason for the next phase, which is phase 3, which is the standard of care versus the new treatment, the study treatment, and then looking at the effectiveness and stuff like that for the 2, and comparing the arms. And when you get a treatment that's better than the standard of care, then it can become the next standard of care. So that's kind of like a real basic way of explaining how a drug becomes approved and used in standard of care. So, but I just want to say that when we have patients on clinical trials, the patients get way more attention, more tests, more, they really kind of get coddled a little bit compared to the regular patients, because there's just so much attention that goes into their care and every little thing. And we have to sign off on their little potassium and every little lab that they get. every detail is being looked at very, very carefully. Their radiology is read by specific readers who measure out every single tumor. So it's not like a place you go to feel like a guinea pig or like you're being abused. It's actually a kind of a special place to be, is on a clinical trial. So I just wanted to kind of put that out there. Sometimes people are very fearful of them. And so lots of side effects. These are all the side effects. It depends on the treatment that you're going to get, how long you're going to get it. There's really no way around it. Not everybody gets all the side effects, but almost everybody gets fatigue. And so that's something that we just really can't help. But a lot of these side effects are treatable with medications and supportive care. We try to help as much as we can to reduce the side effects to make the treatment tolerable and yet maintain efficacy of the treatment. So coping with side effects means like telling people you're having the side effects first, and then we'll do anything we can to help relieve the side effects to make it more tolerable. So palliative care and hospice care, just a couple words on this. Palliative care is kind of an ongoing discussion about a person's goals of care and making sure that they're doing what they want to be doing, that they want to have treatment, that they're or that they don't want to have treatment, and how to improve their quality of life in terms of symptom control and those kind of things. Usually palliative care is enlisted when someone has an incurable cancer, but they're on treatment. They may or may not be responding to the treatment. And we do have kind of an initiative in our practice to try to get everybody some kind of palliative care discussion. We call it supportive care, but it's basically the same idea, just to make sure that they've thought about things. They have heard of the paperwork that should be done, that they kind of think about what they're doing and what they want to do, so that they're not just going along with what everybody else wants them to do. Different from hospice. Hospice is when a person is not having any cancer treatment, and the treatment is really comfort and safety oriented. Hospice means you're not going to be having surgeries or going to the hospital. It means not treating the cancer. The cancer is going to take its course, but hospice is basically making it the best quality of life and comfort during the time that you're not on treatment. So not treating the cancer, but treating everything, all the consequences of the cancer in a person's body, and emotional and psychological and everything. So this slide is, I just want to say, made by not by me, because this puts hospice in a negative light, which is really not ideal in my mind, because hospice is actually a beautiful thing when people are coming to the house and you know them and they're able to like communicate with you about what's going on, and you trust them, you tell them your symptoms, they help you with all your symptoms, and everybody's kind of accepting this is cancer, this is end stage cancer, whatever it is, end stage whatever disease, but there's an acceptance involved. And in the setting of hospice, you have time with your family and you have time with the people you love, and you're not getting spending all of your time in our waiting room getting some procedure that's not going to help you, or some really invasive things that can happen in the hospital that maybe are taking up that precious time that you have. And so I wanted to change the slide, but I couldn't. But I feel strongly that hospice should not be put in a negative light. And so palliative care is wonderful, but hospice is wonderful too. So that's my thing on that. So challenges of living with cancer. So loss of hope, loss of control, living with uncertainty and unwanted aloneness. There's definitely a lot of emotional things, and I can just tell you that there's a lot of shame involved in lung cancer, especially among smokers. And a lot of times people don't want to talk about it to their family even, or to anybody else. I have a family member in my generation who has lung cancer and will not let me come to any appointments, won't talk about it, nothing. And so I understand this is a really big part of it, especially in lung cancer. It's much different from breast cancer and other cancers where there's a I don't know how to say it other than just shame, you know, and a feeling of negativity towards oneself that that is unfortunate for someone to have to feel those feelings, but it's helpful for caregivers to understand that that's a big part of it. So all these levels of distress and everything are good to try to talk about. We have a lot of supportive care services in our clinics and in our practice that help with these, with the emotional side of and the distress of cancer. Positive attitude. This is great. So yeah, actually it does make a difference being positive. It makes a huge difference. I mean, I'll see two patients back to back with the exact same scenario. Everything's basically very similar, but their outlook is completely different. It makes a huge difference. And it's definitely work to have a positive outlook when someone has lung cancer. But if caregivers and people around the patient can help with this, it helps a lot day to day. Yeah, so this is basically the same thing. Helpful to talk about your emotions, definitely. And reaching out for help. Oh my gosh, can I just tell you, I have this patient in the hospital right now who was dying at home alone. We called him 10 million times and he wouldn't answer the phone, and he was too weak to get up. He was too weak to eat, too weak to make food, like anything. He was in bed, dying, almost dead. And someone came to the house and found him, brought him to the hospital. And he, you know, poor guy, like just scared to ask for help. No friends, totally alone. And it's rough. So reaching out for help is not easy for a lot of people. But there's a lot of people, if you can reach out for help, there's a lot of people that can take your hand. So these are good. These are all good things. Hobbies are great. You have to rely on the strength and love of other people. Caregivers, some tips for caregivers. This is tough. Communicate with your loved one's healthcare team. So it's not uncommon for the caregiver to really be the advocate for a patient, and to spend full time with the patient. It is helpful if you can get some support. Caregivers need support and love and separate attention from the patients. Okay, so these are the paperwork. Living will has to do with if you want to have life support and like, for example, CPR, and if you want to be on a ventilator. Healthcare proxy or medical power of attorney is basically a person who's assigned as your decision maker if you're not able to make decisions. Financial power of attorney is separate from medical power of attorney, and that's the person who manages your money when you're not able to do it. And then a will is different from the living will. And that's basically what to do with your possessions and your wishes. So these things should be filled out and completed by everyone, even if you don't have cancer. It's good to have it and to think about the issues that are brought up by this. Even for everybody who even doesn't have cancer on this, everybody should have all these paperwork completed. That's basically what I was going to talk about. I'm going to pass it back to Caitlin, who's going to review these next 5 or 6 slides. that have to do with the cancer support community and their resources and so on. So thank you.
Well, thanks, Dr. Veatch. Yeah, so I just kind of wanted to, briefly go over cancer support community and just the resources that, we offer. Also at just like a national level, this is like a worldwide nonprofit. So one of the things that they offer is a support helpline. And basically this connects you to, it's completely staffed by licensed mental health professionals and resource specialists. And, they provide and kind of do an intake and provide all kinds of resources to you, referrals to local and national, regional resources. They also do open options. It's a great program where, when you're making treatment decisions, if you don't really know the questions to ask or, your concerns, they'll help you kind of create that list for you and kind of walk you through some things maybe you should talk with your oncologist about. And then, as you go on to Cancer Support Community, frankly speaking, they have lots of different resources on different topics. And those things are all available to people in like PDF form. And that's okay. I can share my screen, Dr. Veatch, if you want.
Sorry.
No problem. I have it up and ready.
Thank you.
Yeah, no problem. Let me get, where were we? We're right here. Okay. All right. So all those frankly speaking resources are, available to you, and you can print them out or download them. So that's kind of a great thing to have access to. So the Cancer Experience Registry, specifically for lung cancer, is a program where you sign up and you kind of talk about your experience with lung cancer and your unique experience. And it informs medical professionals kind of about what patients' needs are to help improve that quality of care. So it's confidential, it's secure. It helps providers and researchers really understand the issues that are important to the community. And it does help transform care. So, it's something that affects everybody who's being treated by lung cancer. And it's something great that you can participate in and, include your experience to maybe help better care for other people and yourself. This is how you would join. So if anybody's interested in joining, we can always share this with you. You can always go to the Cancer Support Community's website and sign up as well. But these are the steps to sign up. Cancer Support Community also has like a grassroots movement. So this is kind of a great way to advocate for cancer care on the national level. You can get up-to-date information on issues that really are important, issues that Cancer Support Community is backing. So if you're really interested in legislation and learning more about that, you can also join kind of Cancer Support Community's grassroots movement. So that is really great. And then My Lifeline is a program that they offer where it's basically interactive blogging. So there's some other resources I think out there that are similar to this, but this helps you let your family and friends know how you're doing. There's calendars, there's discussion boards, there's care coordinators. So this is a resource that's also available to you in the community. And it's something that, if you're interested in setting up something like that, that is available as well. And then these are just some kind of larger organizations that are out there. These are, all of their websites. And this presentation will also be available to you afterwards. So, if you're looking to write this down or check these out later, this will be available to you. So that's the end. And we're going to open it up for any further questions that you guys might have for Dr. Veatch or any discussion. Please feel free to unmute yourself and ask away if you have any. Someone did say thank you, Dr. Veatch. This was very helpful in the chat. So
I'm muted. Thank you. I'm glad, I hope there's something anybody learned anything. It was great. Thank you.